Good evening, everyone. Good evening, everyone, for today's session. Today is the fifth session of the uh, teaching program, where today we have the topic pain management with opioids, where opioids are available in India, the mechanism of action, receptors, adverse effects, relative cost of step 2 and 3 opioids will be covered. There will be case-based discussion regarding prescribing the step 2 and 3 opioids also. Again, adverse effects of the drugs and the management will be covered in the session. We have eminent faculty, Dr. Sanghamitra Bora, to cover this session. Dr. Sanghamitra Bora, she did her MSc Palliative Medicine from Cardiff University, UK in 2017. She is a lead palliative care of Assam Cancer Care Foundation. She is also the honorary medical director of Arjun Healthcare Foundation, and she is an active IAPC national faculty since 2010. She is also a national trainer for National Health System of Government of India, Ministry of Health and Family Welfare. She is a very active member of various palliative associations, and above all, she is a close friend of Pallium India. So, we welcome you to this session for taking the session, ma'am. And over to you, ma'am.
Thank you, Rajlakshmi, and thank you, Dr. Manu, for having me here today. First of all, I would like to apologize because it's a long presentation, and please pardon me for if I am repeating anything. Please kindly tell me about that also. But I have tried to make it as clinical as possible because unless and until I think we have a little clinical scenario of managing pain, because I believe as oncologist would be actually getting such clinical scenarios, such patients where you find it a little dicey or difficult to take decisions on which medication to start on, and there would be certain dilemmas that you might be facing. So I will try to make that as simple as possible for everybody. And so I'd like to share my screen now. Okay. Is the screen visible to everyone?
Yes, ma'am. Presentation view would be good.
Yeah. Yeah. Okay.
Good to go, ma'am.
Yeah, great. Okay, so I feel that we need to revisit the main anatomic areas of pain modulation so that once we start fresh from the basic things, we'll be able to relate more to what we are going to learn today. So there are these are the main anatomic areas. As you can see, there is a peripheral modulation where you can see a small hand on the left hand side which has got a pain source, and then there is a spinal modulation leading to processing of the pain stimulus in the areas of pain processing in these cortex, and then there is a supraspinal modulation where the processed pain, actually the signals they come down to the peripheral modulation source. So what happens is that there is a noxious stimuli which initiates some acute physiological pain, followed by stimulation of the nociceptor, the impulses transmitted via peripheral nerves to dorsal root ganglion, and then the messages would travel via the ascending pathway, which is the spinothalamic tract. And there would be inhibitory signals that would be transmitted via the descending tracts. So this is a very simple kind of a mechanism that goes on for pain. I'm not going into much details. but need to know some neurophysiological consequences of pain, which are peripheral sensitization followed by peripheral recruitment, which follows central sensitization and central recruitment. So what happens is that there is a sensitization of the nociceptors. As you can see in the diagram on the left hand side, there is this peripheral nerve where the pain signal has actually come, and there is an insult to suppose there's an insult to a part of your hand, or in the periphery, and the peripheral nerve actually gets the impulse. So what happens in that particular area is that the nociceptors which are present, the nociceptors are the ones which are going to carry this pain signals. Okay, so these get sensitized, and there is an immediate release of analgesic mediators, and these analgesic mediators are mainly prostaglandins, potassium ions, histamine, leukotrienes, bradykinin, substance P, etc. So these things get released in that particular area, and the main work is actually done by prostaglandin, which sensitizes the nerve endings so that other mediators, which other analgesic mediators, they could cause could cause a progressive nociception of the pain. They could carry away this pain through the peripheral nerve. So the main learning point at this particular stage is that if we treat the pain at this particular point with NSAIDs, the nociception or the carriage of the pain insult through the analgesic mediators can be stopped. So basically we are actually blocking the prostaglandin, the synthesis of prostaglandin, by treating with NSAIDs. So peripheral sensitization is a very the first stage, you can say, in a layman's language, the first stage of pain, where it is totally located in that particular area only. It is not being carried by, it is an impulse which is being signaled that there is a insult in this particular area and we need to treat this pain. So what happens if we do not do anything at this point of time? So this goes into another mechanism called recruitment. So what happens in recruitment? You see this black colored peripheral nerve. The normal nerve is the black colored one, but then you can also see the red ones. Okay, so these red ones are actually the silent or sleepy nociceptors. They are present in that particular periphery, but they are actually not active at all. But when we do not treat the pain right at the point of peripheral sensitization, the pain actually travels, and the silent or sleepy nociceptors, they get recruited to do the work. The analgesic mediators actually, tickle them to get up from their sleep and then work towards carrying the pain forwards. And what happens is that both these mechanisms, they can be triggered and maintained by the release of substances in the periphery from the nociceptive terminal itself. So once we do not even treat, when we know that it has been peripherally sensitized, there is a stage where the central nervous system also gets, sensitized to this particular pain stimulus. So they are sensitized, the CNS is sensitized by the nociceptive inputs. There is a repeated C fiber stimulation. The C fiber, if you remember your a little bit of anatomy from your MBBS days, the C fibers are actually responsible for delayed and dull kind of a pain. Okay, so there is a repeated C fiber stimulation after the CNS is sensitized, and the C fiber stimulation generally progresses there is an increase in the number of electrical discharges in the nervous system, and there's something called the wind up phenomena, where the whole nervous system actually gets sensitized to a minor insult in the periphery. So basically, if we do not treat pain in the first stage, which I mean to say is peripheral sensitization, there is another process which comes into play, which is called a peripheral recruitment. If the peripheral recruitment is also not treated, there is a chronicity that develops in the pain, and this includes the whole central nervous system. And at one point of time, the central recruitment process also takes place. And when it is generally it follows the recruitment of the central nervous system. If we do not treat the pain at that point of time, the result of all these changes is something called the secondary hyperalgesia. And this is an increase in pain sensitivity when a noxious stimulus is delivered to a region surrounding but not including the zone of injury. So the zone of injury is present, but if you touch maybe 6 to 7 centimeters out of the zone also, there is pain, severe pain experienced by the person or the patient. And this is called secondary hyperalgesia. Secondary hyperalgesia is a dangerous phenomena, and pain has to be treated right at the point of initiation because of the fear of developing secondary hyperalgesia. So based on the time, we can divide pain into two groups, mainly the acute pain and the chronic pain. So the acute pain is actually considered a symptom. It has a positive effect on the person because it actually denotes some kind of underlying mechanism, underlying disorder that can be treated, and it is associated with certain signs and symptoms like pupillary dilatation, sweating, increased blood pressure, tachypnea, tachycardia, etc., etc. On the other hand, chronic pain, which is considered to be chronic only after the pain is more than 3 months old, it is actually a disease. It cannot be considered a symptom. It has a total negative effect on the person because it reduces the quality of life of the person. There are no signs for the chronic pain that remains in that person. As seen in acute pain, it causes a lot of sleep disturbance. There is anorexia, there is dysplasia, there's anxiety, and it overall reduction in the quality of life of this patient. So, types of chronic pains, we divide it into two basic groups, the nociceptive pain and the neuropathic pain. This is a simple diagram of the peripheral nerve getting, synapsed in the dorsal horn ganglion. And the nociceptive part is the one where the receptors, the nociceptors are actually present, and the pain is confined only to the nociceptors, and rest of the part from the peripheral nerve to the dorsal horn and above would be considered as a neuropathic pain. So this is the types of chronic pain that we generally deal with cancer patients. So pain is also divided into, visceral and somatic pains. As the word suggests, visceral is related to viscera. It can be a capsular pain. It can be a bowel movement pain. It is also related to cardiac pain. Somatic pain, on the other hand, is related basically to the bone and the soft tissues. The neuropathic pain, on the other hand, is definitely due to a nerve compression or a nerve injury, basically the peripheral nerve, the sympathetic nerve, and the central nerve. So manifestations of pain are, nature of the pain, burning, pricking, aching, shooting, lancinating, or any kind of, a kind of displeasure or a description actually given by the patient. There is a typical neural or dermadomal distribution. There is the if it is centrally recruited, then definitely the phenomena of hyperalgesia and allodynia. So how do we assess pain? What is pain assessment? The main mantra of assessing pain is review, review, and review. You have to review the patient all the time after you give medication, okay, before you plan out an intervention. So you need to review all the time. This is the basic underlying assessment mantra that we do. So generally speaking, we have to take a pain history, and in the general history, we take the response to analgesics, response to other treatments, associated physical symptoms, interference in activities of daily living, etc. And then examination of the area of the pain, and of course, the general examination, and few investigations. So clinically speaking, when we take the history of the pain, we follow a mnemonic which is O, P, Q, R, S, and T. And you can actually remember it very easily. It's absolutely, to the point. I mean, when you actually take the pain history, you need to understand the occurrence of frequency of the pain, any precipitating or provoking factors, as well as the palliating factors, something which reduces the pain. Then coming to the quality or character of the pain, radiation of the pain. Does the pain actually go or radiates towards any other part of the body? And then site of the pain or area of the pain, severity or intensity of the pain, and duration of the pain. Now we talk about, basically, when we assess pain, we talk about assessing the intensity of the pain. So coming to quality of the pain, we know that the chronic pain are two types, which is nociceptive, another one is neuropathic. When we talk about nociceptive, the patient might give you a description like it is a wound like pain, it is aching, or there is a gripping sensation. So these are basically actually pointing towards a nociceptive kind of a pain. On the other hand, when if the patient is actually telling you that there's some kind of numbness that I feel over this area, or it's lancinating, or there is a shooting kind of a pain, a feeling of a raw skin, or chilies being rubbed, a burning sensation, a bag of worms, crawling of ants, all these descriptions actually fit into the neuropathic pain type. Intensity, we generally measure intensity of the pain by certain tools that are validated tools. There is something called the numerical pain scale. I'm absolutely sure that all of you know about the numerical pain scale, and you must be practicing it in your day-to-day oncology patients also. Wong-Baker Faces pain rating scale is generally used for children in pediatric oncology, and then the 5-finger scale. So there are other, assessment questionnaires that we generally use, or those are generally for the research purposes. Those are McGill questionnaire and brief pain inventory. But in our OPDs, we generally use the NRS numerical pain rating score. So the we need to understand that the patient is the best judge of his pain. So we need to believe the patient always about the type of pain that he is trying to tell us. So it is on our onus to know the quality of pain, to understand the intensity of pain. So how do we do a pain assessment?
Dr. Sanghamitra, can I intervene for a second?
Yes.
Like they already had a session on pain assessment and management and NSAIDs too.
Okay. Okay. So, all right. So, thank you, Rajlakshmi, for telling that to me. So, I'll just skip this part and come to pain management. Okay. Is that all right?
Yes, ma'am. Yes.
Yeah. Okay. So, uh, so managing pain would be actually, looking for the cause of the pain, and that is the basic principle that we need to understand. We have to correct the correctable, and when we talk about correcting the correctable, we need to understand: is the pain because of irradiation? Is the pain because of chemotherapy? Is the pain because of surgery? Or is the pain because of any other cause that is that can be corrected, that can be taken away, so that the pain is treated? So basically the principles of pain management is a prompt treatment, prevent the main idea is to prevent the recurrence. We have to set some realistic goals, like achieving a good night's sleep for this particular patient. uh, Always we need to understand that the pain ladder, analgesic pain ladder, which I'm sure you have already learned about, we need to understand that we have to go by the mouth, by the clock, and by the ladder. And then everything has to be tailor made for one individual. It cannot be, one treatment, one regimen fits all. Okay. And there is this role of the adjuvant drugs. So treatment basically is, we do start from non-pharmacological methods, taking on to pharmacological methods and interventional techniques and combination treatments. So I'm not going into these. I'm sure you also know about WHO analgesic ladder, so I'm not going into that also. But just to start with the usage of strong opioids or step 2 and step 3 drugs, let me just put forward this particular patient who's Mr. X. So you can see in the picture the kind of faces or kind of emotions that this patient is showing at this point of time. So he is a 56-year-old patient with CA larynx. There is pain around the neck, and when you evaluated, the pain was 10 on 10 in the NRS scale. It is sharp. The patient is not complaining of any kind of radiation from the neck, and it has been happening since the last 2 weeks. Patient is not able to sleep at all. So my question to you is, how will you manage this pain? So you can actually put your thoughts on the chat box, or you can talk also. I just need 1 or 2 responses so that we can actually take this forward. Can I have just one response? How are you going to manage this pain? So you've already...
IV morphine.
Sorry?
IV morphine.
IV morphine. Okay. So how have you actually come up to this conclusion that we need to give him IV morphine?
Ma'am, as the pain indicates 10 by 10, which is the worst pain experienced by the patient, we can straight away go to the WHO analysis later step 3, strong opioids.
Okay. And how much morphine, IV morphine, are you going to give this?
Ma'am, we have 1 ml morphine equal to 10 mg and the 15 mg. So we dilute into 10 ml NS, which becomes 1 ml equal to 1 mg. And before giving the IV morphine, we check the vitals, drowsiness, the pain score, followed by 2 mg IV morphine stat. And we wait for 10 minutes and we check again the vitals of again the drowsiness, the pain score, and the heart rate, pulse rate. And then again we assess the pain, and then again we give 2 mg. In this way fashion, we continue till the patient experiences minimal to no side effects with high relief of pain, and then we later convert into the oral morphine.
Right. So this is actually, you are talking about the intravenous morphine trial. Okay.
Yes.
So Right. So definitely, absolutely right. Absolutely right. So we have to find out how much morphine, since we have already seen that the patient has a 10 on 10 pain. So we directly go to the step 3 of the ladder, which is the strong opioids. But we need to find out how much morphine this patient requires. So that is the reason why we need to do a intravenous morphine trial. As the doctor said that, it is 1.5 milligrams at an interval of 10 minutes. So what we do, we have a 15 milligram per ml of ampule of IV morphine. We have to dilute it with 9 ml of distilled water, and then the dilution actually gives us 1.5 milligrams every ml. All right. So so we secure an IV access and we give 1.5 milligrams at an interval of 10 minutes. Now the point is, we have to look after the immediate side effect of IV morphine also. Okay, and check whether the patient has had any other opioid before for this particular pain. Now, taking care of these two, questions will actually uh, keep the patient safe and keep our skins also safe. All right. So that is the reason the immediate side effect that we expect for IV morphine is generally vomiting. All right. So now, in case the patient, if we understand that a patient might have vomiting, we need to give him injection metoclopramide 10 milligrams IV. So I'm sure that you know about the side effects of morphine also, because you have already had this class before. So we need to first give this patient 10 milligrams of IV metoclopramide. Why metoclopramide? Because it is a prokinetic, it is also centrally acting, and this is the reason why morphine induced vomiting would be taken care by metoclopramide. So this is and at the same time we need to also understand the endpoints, as you have correctly answered. It has to be a satisfactory pain relief or sleepiness, whichever is earlier. Now, we cannot actually we cannot actually take it for granted that the patient will be responding to morphine. It might also happen that the patient doesn't at all have pain relief, but he becomes drowsy. The reason behind is that uh, only 45% of all pains are morphine responsive. Okay, so we have to take these facts into consideration and then go ahead with the IV morphine trial. So we do a IV morphine trial and see the endpoint, which is either sleepiness or the satisfactory pain relief, where the patient says that I have, now I feel it's 1 on 10. So this is a small chart that we have in our OPDs, where we use it for recording it. Our nurses do it generally. So suppose you have given 10, at 10 a.m. in the morning, you've started the morphine trial, and the pain score at that point of time was 10. Not going into PR, because you have to actually record the pulse rate, respiratory rate, and the blood pressure, and then see whether the patient is drowsy and how much injection or morphine you have given. So like this, every 10 minutes you repeat, you ask the patient about pain relief, the pain score, you record it, and then maybe around 10:30 the patient says that I have a score of 1. I feel quite relaxed. I'm relieved of the pain, and I have just one. So you now have these 3 dosages, which so you can see that after this trial, the patient is absolutely fine. He's smiling. So now we have given 4.5 milligrams of IV morphine with good pain relief. So we know that it is 4.5 milligrams of injection morphine that is required for this patient. So how do we convert IV morphine to oral morphine? So, IV morphine generally works at an, within 10 minutes of injection. All right. And it is similar to that for the subcutaneous also. So if you do not have a, injection access, I mean, IV access, you can always opt for the subcutaneous route also. But when we have actually come up to the conclusion that the patient needs oral morphine of 4.5 mg equivalent of the injection morphine. So we need to come up to the best possible oral option. So that would be around 5 milligrams of oral morphine every 4 hours. All right. So you give half tablet when he wakes up, maybe around 6, then half at 10, then 2, 6. And this is the chart that you can actually give the patient to follow at home. So in case, if you do not have a IV morphine access, or you do not have an IV morphine storage, then you can also do a oral morphine trial for this patient. So for those patients who are opioid naive, by opioid naive, I mean to say that the patient has never taken any opioids before, or the last dose of opioids, even if the patient was on opioids, the last dose were taken 3 months back. So those patients are considered as opioid naive patients. And we start oral morphine trial with 5 milligrams of for opioid naive patients, and 10 milligrams for those already on weak opioids. So these are the basic principles of introducing the strong opioids for ongoing pains. The indications are the pain unrelieved by non-opioid analgesics. The starting dose would depend on previous opioid exposure, the age of the patient, and the severity of the pain. And always remember that continuous pain requires continuous background analgesia. If we do not follow this rule, then maybe we will not be able to take care of the pain. So coming back to Mr. X, so we have started him on 5 milligrams of oral morphine every 4 hours, and also advised an SOS dose. And the SOS dose would be actually in between 2 doses. Whenever he has a breakthrough or incidental pain, the patient can be advised one similar equivalent dose of morphine tablet that he's already taking. Okay, so he was started on 5 milligrams of Q4H morphine and SOS dose. He was relatively pain-free for next 2 weeks, but now, he needs 4 SOS doses of morphine every day for the last 4 days. All right. So he comes to you with this particular problem. So what shall we do now? Can I have some responses on this? Any responses on this particular question?
The patient is on 5 mg Q4 Tarli, which is total is 30 mg per day. And right, for past 4 days, he's taking 4 SOS, which is equal to additional of 30, he's taking 20 more. So roughly equivalent to 50 mg is being on this thing. So
Yeah.
we can increase the dose to 10 mg Q4 hourly based on the profile with 10 mg SOS.
Okay, that's correct. So the rule is that when two or more than two doses, SOS doses are taken, we increase the dose by 30 to 50% over the next 2 to 3 days. And over the next 2 3 days, we have to observe the patient, whether the patient has, does he need more morphine, or does he, is he slipping into the vicious cycle of, getting more side effects. So you have to observe whether the patient is getting complete pain relief after increasing the dose by 30% first. So when he is on 5 milligrams of morphine, you need to increase slowly to 7.5 milligrams. And then if he is not responding to that, please increase it to 10 milligrams of Q4H morphine. Yes, that's correct. So the question is, how frequently will you give SOS doses for morphine? And why will you do that? Any response?
Madam, there's an answer in the chat box. Dr. Azura, she has written, we can increase the dose.
Okay, I understand we can increase, but my question was that
earlier questions
that was a that was an early response. Doesn't matter. So for to understand how frequently we can give SOS doses of morphine, and if we have to give it an oral, why we need to do that, how we will do that, we need to understand little bit about this particular wonder drug. Okay, so I'm sure you have seen all these pictures before, and the most potent part of the alkaloid is the white sticky substance that actually comes out when you cut the unripe capsule of this particular poppy flower. Okay, and it's called Papaver seminiferum, the scientific name of poppy flower. So the whole tree of the poppy plant is actually filled with morphine and its substances. Everything about the whole plant is morphine. So the most potent part that is extracted is from the sticky white gum. So the pharmacokinetics, if we know about little bit about pharmacokinetics of morphine, then maybe we'll be able to answer that particular question. So morphine is a weak base. Okay, it is it is absorbed very nicely in the alkaline medium of the upper small bowel. All right, and since it is hydrophilic, it has a slow onset of action, but a longer duration of action. Henceforth, the sublingual absorption is very, very low. There is perhaps no sublingual absorption, and the buccal and gingival absorption, there is very varying evidence about this particular two routes, because many people are tempted to actually give sublingual and gingival morphine, okay, just for a SOS kind of a thing. And since it is a little bitter in taste also, these routes are not preferred. Now, it passes through the first pass hepatic metabolism. It is swallowed, it goes to the GIT, it is absorbed into the blood vessel, then it is, goes into the portal circulation, then to the liver, and in the liver it is metabolized and it is distributed in the systemic circulation. Now, metabolism of morphine mainly happens in the liver, and little bit minor part is also happening inside the GIT and the kidney. And 90% of the oral morphine that is taken is converted into metabolites. And out of these metabolites, 40 to 55% is morphine 3 glucuronide, whereas 5 to 10% is morphine 6 glucuronide. And morphine 6 glucuronide is actually the active component that is responsible for pain relief. And it is postulated that M3G or morphine 3 glucuronide is actually, it causes the side effects. Okay. So this is about the metabolism of morphine. So coming back to our question of how frequently we will give the SOS dose, the active metabolites, we have to understand that they start action only after 30 minutes of entering the systemic circulation. So we can give the SOS dose every 1 hour. All right. We can actually give the patient every 1 hour. It is, we should not be stopping ourselves to give the patient, if he's having, say, 30 milligrams of morphine every 4 hours, and he has pain, and we are hesitating ki itna sara to morphine kha raha aur kitna denge. It should not be like that. Okay. Please remember that active metabolites of morphine start their action after 30 minutes of entering the systemic circulation. So we can give SOS doses every 1 hour. So this is the answer to that particular question. Now, Mr. X's pain has been stabilized with 10 milligram of oral morphine 4 hourly. We have increased it to 10 milligram. But he finds it difficult to take it every 4 hours. Okay. He says, nahi, itna to aapne kar diya. Now I don't want to take so many morphine. He says that please reduce my dose, or please reduce the frequency so that it becomes less cumbersome for me. Okay. So what will we do now? So we use the sustained release tablets. The duration of action is 12 hours for whereas for fast acting or immediate release tablet, it is 4 hours. And so convert the total daily dose to 2 divided doses. So that becomes our sustained release tablets dose. So the duration of action is 12 hours, and we have morphine SR tablets, which are 30 milligrams of 30 milligram BD. So these are the formulations of morphine. Aqueous solution, we have in the form of solutions also that are used for kids, that can be used for patients who are on Ryle's tube, and there are tablets of immediate release and controlled release, and then injections. Injections also come in 10 milligrams per ml and 15 milligram per ml. So now he was on a 10 milligram morphine every 4 hours for the past 6 months. But he was brought to you with excessive drowsiness. And upon investigation, it was found that he has a serum creatinine of 5 milligrams per deciliter. So will you do anything with the morphine dose at this point of time? Can I have some responses?
And we have to either reduce the dose or change to something which in the renal friendly opioid, if available.
Right. So we have to understand the excretion of morphine at this point of time, because his creatinine is 5. Okay. So let us understand how morphine is excreted. So it is excreted definitely by the kidneys, by glomerular filtration. Interestingly, morphine 6 glucuronide it accumulates in renal failure. Okay, and this person might be having some kind of renal disease, underlying renal disease, or have developed due to some problem. He has developed a kind of a renal failure scenario. So the clearance is decreased and the half-life is increased. Okay, clearance of M6G is decreased and the half-life is increased. So for Mr. X, we will increase the spacing and make the dosing TID. We will not give him, these are options that I'm giving. We will not give him every 4 hours. We will actually give him every 6 to 7 hours. Okay. And we will also have to reduce the dose, or we use alternate opioids, as the doctor has already told. Okay. So now he was sent home and he is now taking morphine 5 milligrams every 8 hours, right? After 2 months, he was unable to swallow anything, including morphine, due to disease progression. So what are we going to do for pain relief now? Any response?
We can use transdermal patches.
Yeah. So we need to understand about the routes of morphine administration. How can we administer morphine? Are you actually talking about transdermal fentanyl, doctor?
Yes, madam. Yeah, I was talking about.
Yeah. So you see, being in palliative care, I am a little, I feel that our patients have already undergone a lot of monetary financial problems. And I really don't want to, give him any kind of burden from my side. Okay. This is my personal take. Okay. So I really don't want to give him any more burden from my side, because morphine would actually cost him far less than one patch of fentanyl. Okay. Until and unless it is extremely dire necessity on my part, on his part. So, sorry. So, let us understand what are the other routes of administration of morphine. Okay, so we have intravenous or subcutaneous route. We have an oral route. We have a per rectal route also, and an epidural route and an intrathecal route. So for this particular patient, I would like to actually give a per rectal route, which has a similar absorption, just because I told you about the small bowel upper GIT, but the rectal part also gives a similar absorption of morphine. And once the patient is not able to take morphine orally, you can actually advise a per rectal administration also. So okay, so now he was sent home and is now taking morphine 5 milligram Q8H because of the renal problem that he has shown. After 2 months, he was unable to swallow anything, including morphine, due to disease progression. So for pain relief, we will try to give him 5 milligrams of per rectal morphine every 8 hours. And that should be a fast acting tablet. We can definitely, give him a prescription of fentanyl patch. But before thinking about fentanyl patch, I would prefer to give him a per rectal morphine. So, yeah, any questions at this point of time?
Madam, there are two questions. One is from Dr. Devi Kiran regarding rectal route morphine is same oral form of morphine. Do we need to make a paste? That's one question. Another option was by Dr. Shraddha. How about Ryle's tube insertion and giving morphine?
Okay, so you can actually think about putting a Ryle's tube, but since the patient is already, the disease has progressed, I'm sure the oncologist who's actually taking care of the disease part will definitely think about putting a Ryle's tube. And if there is a Ryle's tube, you can actually powder the morphine, but not the sustained release morphine. Okay, you can powder the fast acting morphine. You can mix it up with any kind of a liquid, maybe water or any other liquid that you think of, and then give it through the Ryle's tube. That can be done, definitely. But talking about the per rectal morphine, you do not need to make a paste. Okay, there is no need to make a paste. You can just, it's a very small tablet, you know it. I mean, you can just push it in the anal canal, just as you do it for giving an enema, and it acts similar with similar efficacy. Okay, so we have done it for children also, and we do it most of the time for our oral cancer patients. I'm from the Northeast, I belong to Assam, and we have 80%, almost 80% of our patients are head and neck cancer patients. And for that, either we give them it through a Ryle's tube, and if the Ryle's tube is not there, or for some reason the patient is quite terminal, we actually prefer the per rectal route.
Ma'am, just the same morphine which you said 5 mg. I have no experience per rectal. That's why I was asking multiple times. The same thing, we can keep it insert into the anus. That's what you're saying, to the anus, or
Yes,
leave it.
yes.
Yeah.
The same thing.
Okay.
There is no other formulation of morphine tablet for per rectal use. It is the same tablet, the oral tablet morphine, which you can use per rectally. Okay. Yeah. So I'm actually going to another case of Mrs. Y. So she's 55 years old woman with CA colon, and she has abdominal pain, which is continuous. She is on 10 milligrams of morphine, Q4H every 4 hours, and she doesn't require any SOS dose of morphine. So it is like she's happy with 10 milligrams of morphine. Now, she's able to take afford fentanyl patches, so she was given 25 micrograms of fentanyl patch instead of having the oral morphine, because the pain was stabilized also, and she said that okay, just relieve me from my tablets, I need to I don't want to take every 4 hours. So the specialist actually gave her 25 micrograms of fentanyl patch. But next day, the patient actually comes to you, and she said that she replaced the patch after 5 hours, as she had no pain relief. So at this point of time, what will you do? Any responses?
As the patch morphine, as the patch fentanyl, which works only after 12 hours.
Yeah.
So the patient should take the morphine tablet as a scheduled dose for the first 12 hours, and later to switch to SOS based on the breakthrough pain dose.
Absolutely.
Which we should
Absolutely.
explain. Which you should explain, because most of the patients, they generally come to us after removing after 5-6 hours. Man, definitely they come and say this is a expensive, useless patch which is not giving anything relief to us.
Right. Absolutely right.
Multiple times we have.
Hello. Hello?
Yes, ma'am. Go ahead, ma'am. You can listen.
Yeah, no, I actually couldn't hear what he was saying. So that's okay, absolutely fine.
Okay.
So that's a correct
Yes, ma'am.
response.
Yeah.
And you know, we have to understand few things regarding fentanyl formulations also. So fentanyl is lipophilic as compared to morphine. Okay. So when we give it for injection, it is short acting. So it you know, acts in half an hour to 1 hour. But if we have to give the patient a continuous analgesia by means of fentanyl injection, then it will require a continuous subcutaneous infusion. Okay, and it comes in the dosage of 100 micrograms per 2 ml of ampule. Now, we are talking about the transdermal fentanyl patch because that is what is circulating in the market. Okay, so what happens is that when you put the fentanyl patch on the hairless area of a body of the patient, it forms a subcutaneous depot. Okay, there is a subcutaneous depot, and unfortunately, the peak is reached only after 8 to 12 hours. Okay, not before that. Since it is lipophilic, it has a slower action, and the depot generally starts an effective analgesia only after 8 to 12 hours. All right, so that analgesia will definitely last for another 72 hours. Now, there are certain conditions which actually affects the absorption also, like the condition of the skin, the temperature. If the patient has high fever, you know, the absorption is actually increased. It may not be suitable for titration. And for an opioid naive patient, we do not know how much how much fentanyl is required because we cannot titrate a fentanyl patch. Okay, so it is not suitable for titration. It is also not suitable for opioid naive patients, and it is not suitable for unstable pain. So until and unless you are confident that the patient has a stable pain which is responding to a certain amount of oral morphine, and you can actually then transfer the patient to fentanyl patches. Okay, so what are the things that we need to understand here? So suppose this Mr. P, suppose there's a Mr. P, who he is 70-year-old man. He is with carcinoma of the lung. He's complaining of throbbing pain on the right front of the chest. The pain is continuous, 5 on 10. He is a known epileptic and on phenytoin, 100 milligrams of BD. So how will you manage this pain? How do you manage this pain? So we need to understand that tramadol is a step 2 drug. Okay. Hello, am I audible?
Yes, ma'am, you are.
Yes, ma'am. Yes, ma'am. You're
So we have to understand that tramadol is a step 2 drug, but it reduces the Scheser threshold. So for any patient who is a known epileptic, is already on an anti-epileptic like phenytoin, we must not actually use tramadol. At the same time, we will have to be very, very careful for using tramadol as an injection also. All right, because if we do not know, if the patient is actually not giving any kind of history about, having seizures or kind of a potential that that patient might have had, any no other records are available, we have to be careful while using tramadol use it slowly, use it very judiciously by diluting it with 100 ml NS. I'm sure you must be doing that in your OPDs and IP patients also. But having said this, you need to know how to choose the right opioid for right kind of patients. So, okay. Now, there's another scenario here. This particular patient is on 50 milligrams of morphine, Q4H, and she reports to the hospital with severe pain. Okay. You have injection pentazocine and tablet morphine. Sorry, it is not 0, it is 10 mg. Please read this as 10 mg. You have pentazocine injection and tablet morphine 10 mg. So how are you going to manage this pain? She comes to you with severe pain and she's already on 50 milligrams of morphine. Any responses? Okay, so here we have to understand what what the term opioid generally would mean, because the structure of opioids is actually related to the kind of interactions that two opioids might have with one another. I'm coming to the details now. So opioids are a general term that includes naturally occurring semi-synthetic and synthetic drugs which produce their effects by combining with opioid receptors. And they are stereospecifically antagonized by naloxone. So what does it mean? It means that, the opioids which are classified into agonist, antagonist, and agonist-antagonist together will have different kind of receptor interaction. Okay, so what is an agonist? It is a drug which has an affinity for and binds to cell receptors to induce changes in the cell which stimulate the physiological activity. So agonist opioid drugs have no clinically relevant ceiling effect to analgesia. Okay. Now, what is this ceiling effect? So, whenever we are giving an opioid to a person for pain relief, we have to understand that as the dose is increased, the analgesic effect will also increase in a log linear fashion. You can see on this particular graph on your left side that as you increase the dose of the opioid, an effect of analgesia will also increase until either the analgesia is achieved or the low dose limiting adverse effect supervenes. Okay, so this, I hope you know about this particular thing. Okay, so this is called the devoidance of ceiling effect in case of an agonist opioid. Okay, now what are the agonists which do not have ceiling effects? They are morphine, codeine, oxycodone, diamorphine, oxymorphone, pethidine. So those opioids which are actually available in India are very few out of this, and they are morphine, codeine, pethidine, fentanyl, dextropropoxyphene, and tramadol. So all these agonists do not have any ceiling effect. So until and unless you reach, you see that the patient is actually having side effects or the patient has had proper pain relief, you can actually go on increasing the dose. So on the other hand, antagonists are those which have no intrinsic pharmacological action, but they can interfere with the action of an agonist. Okay, so these antagonists will actually, they are competitive and they will bind to the same receptor and they compete for receptor sites. Okay, both the agonist and the antagonist will actually compete for the receptor sites, and the examples are naloxone and naltrexone. That is the reason whenever there is a opioid poisoning, we generally use naloxone to reverse back. All right, because the naloxone, being an antagonist, will compete for the mu receptor sites and that will displace the opioid, thereby reducing or reversing the effect of the agonist opioids. Another term which we just saw was the agonist antagonist. They are both agonist and antagonistic in nature. They have a ceiling effect of analgesia, and although they produce analgesia in opioid naive patients, they can precipitate withdrawal in patients who are physically dependent on morphine-like drugs. And agonist at one receptor, and they are antagonist on the other one. Okay, for example, pentazocine and buprenorphine. Okay, pentazocine that we use, it's commonly known as Fortwin, TG-Gesic, or Bupatch. Those are buprenorphine. So these are partial agonists. They have low intrinsic activity. The ceiling effect and net reduction in pharmacological action when administered with an agonist. That is the reason why, in this particular graph, as you can see, you can actually keep on increasing the dose of an agonist like morphine till the pain relief is achieved, but you cannot keep on increasing the dose of pentazocine or buprenorphine for reaching adequate pain relief, and they have a ceiling effect. So there's something called the mixed agonist antagonist also, where drugs like pentazocine, they have a agonist effect at the kappa receptors, and they are also weak antagonist effect at mu receptors. So now, since morphine is mu agonist, or morphine actually takes its effect after binding to the mu receptors, since pentazocine also has a weak antagonistic effect at mu receptors, if you give morphine and pentazocine together, pentazocine will then try to replace morphine from mu receptors, and resultant will be an increase in the pain because morphine is being replaced by pentazocine. Henceforth, in that particular example where you had pentazocine injection and you had 10 milligrams of morphine, you have to consider that pentazocine is not the answer of choice. There is always a tendency to give an injection like pentazocine when the patient comes to you with severe pain. But then if the patient is already on 50 milligrams of morphine Q4H, you have patient comes to you with severe pain and you are giving pentazocine injection, you are actually increasing the pain of the patient. Okay, so please do not give pentazocine injection. Consider giving tablet morphine. Use 50 milligrams of morphine, the same amount of morphine that she was taking. And before doing that, please take a proper history, whether she has missed any dose of morphine. Okay, whether the patient has missed any of the doses of morphine. And in my career, I have actually seen patients, while the pain is being stabilized, they just forget to take their drugs and they land up in severe pain. Okay, and when you take a proper history of this such patients, they will definitely say कि yes, उस वक्त तो हमने नहीं लिया था, तब नहीं लिया था, दवाई नहीं था, or whatever, you know. So but then please do not panic, or please do not get tempted to use injection pentagocin or any other, or even tramadol for that matter, because it is not going to be equivalent for that patient. So coming to little bit of side effects of morphine, adverse effects with therapeutic doses. You must be knowing about constipation, nausea, vomiting, sleepiness, tiredness, etc. And a little bit of other, effects, adverse effects are itching, pruritus, dry mouth, and urinary hesitancy. Constipation, about 95% of patients land up in constipation with oral morphine, and it actually generally lasts long. So that's the reason why we have to prescribe a stimulant laxative like bisacodyl. Okay, generally we are using Dulcolax suppositories or Dulcolax tablets for patients, and we have to understand that we must not prescribe any kind of bulk forming laxative like Senna or Isabgol, etc. As they are contraindicated. They can actually lead the patient to obstruction. Okay, so nausea and vomiting, it occurs in 1/3 of our patients in the first few days. It's generally self-limiting. But having said this, we have to use drugs that acts on the chemoreceptor trigger zone because the nausea vomiting occurs generally due to the stimulation of CTZ. And we need to use D2 receptor antagonists, and like haloperidol is an excellent drug, and we rampantly use haloperidol for our patients. Others are, if you do not have haloperidol, then definitely metoclopramide and domperidone. Sleepiness and tiredness, it occurs in 1/3 of our patients upon initiation. It is also self-limiting. You need to actually, tell the patient that it's going to get over in another 2 or 3 days or maximum 5 days. But then please do not think like leaving the medication because you're too sleepy or too tired. Itching and pruritus is a very important side effect, but it is not very common. But when it comes to a patient, it is extremely difficult for the patient to manage. So the mechanism why it happens is really not clear. There are central receptors like serotonin. They might have a role to play. So drugs like ondansetron, which is a serotonin 5-HT3 receptor antagonist, they are very useful in morphine-induced or opioid-induced pruritus. If you are tempted to use medications like cetirizine or cetirizine hydrochloride or levocetirizine, no, they're not going to work. So for morphine-induced pruritus, it is always serotonin 5-HT3 receptor antagonist like ondansetron. Toxic effects are seen when the administered dose is higher than the dose required for pain relief, or when the pain has poor response. And those are delirium, myoclonus, and drowsiness. So there's certain myths and facts that I would like to share with you. It is a myth that opioids will cause respiratory depression. In fact, there are at least 2 RCTs that actually is a higher level of evidence which shows that usage of low dose opioids in patients with COPD and patients of carcinoma lung with breathlessness is actually, it reduces the air hunger or the feeling of air hunger for such patients, thereby reducing the respiratory drive. Okay, so please do not hesitate to use morphine or other opioids for patients with breathlessness also. So the fact is that the patients take their medications by mouth combined with the normally gradual dose and ensure that respiratory depression is unusual. And whenever you see that there is a respiratory compromise, please always think about an alternative explanation such as pneumonia or pulmonary embolism or cardiomyopathy, or co-administration of medications, especially the sedating medications like benzodiazepine. So this is a very important fact that everyone must understand. Opioids generally do not cause addiction at all. Okay, the substance abuse as a result of medical use is really, really low. There is a confusion between physical dependence and psychological dependence. Physical dependence is not at all addiction, whereas psychological dependence is. So if we have to talk about addiction, it is a primary chronic neurobiologic disease with genetic, psychosocial, and environmental factors influencing its development and manifestations. There is an impaired control over the drug use. There is a compulsive use. There is continued use despite the harm and craving. Whereas physical dependence is a state of adaptation that is manifested by a drug class specific withdrawal syndrome. For example, if we stop beta blockers, then perhaps the patient is going to get a heart attack very soon. So that is physical dependence. Another example is stopping the use of oral hypoglycemic drugs in a case of diabetes mellitus. So that is physical dependence, and it cannot be similar to psychological dependence, which is addiction. So last slide of this evening is, as I already stressed upon the fact that we need to understand the financial constraints of this of patients that come to us, because I work in a philanthropic organization headed by Tata Trust, and we have started our hospitals 1 year back. Out of 18 cancer hospitals in Assam, right now we have 7 cancer hospitals. The other hospitals are now being constructed. Our hospitals have seen a huge number of below poverty line patients. And it is pathetic to see the suffering of these patients and the way they, they crave for some bit of treatment that might be available for them at a low cost. Okay, so while practicing palliative care also, even when we understand that the patient is actually unable to afford one single tablet of morphine, we cannot actually go on to prescribe fentanyl patches. And as I said, until and unless it is dire necessity. So this is a small slide. You can actually see the price difference, cost per day for a patient. So I leave it up to you how you manage your patients with low cost medications, which are also available and much more effective than much costlier medications. So thank you so much for a patient hearing, and I can actually answer your questions if there are any. Thank you.
Ma'am, I have two questions. It's a wonderful presentation. I have two questions regarding
Sir, I can't really
one, how will
because your
we address the end of dose pain? Hello, ma'am. Am I audible?
Hello, Dr. Ravi.
Hello.
now you're
Hello,
audible.
sir.
Dr. Ravi,
Ma'am,
is
am I
there
audible?
any connectivity? Can everyone hear?
I think Dr. Ravi, you can switch off your video and try to speak.
Ma'am, am I audible now?
Yeah.
Ma'am, I would like to know how we address the end of dose pain. Like if we scheduled at 6 a.m., 10 a.m., 2 p.m., if the patient gets pain at correctly at 9:30, 9:25 p.m. or 9:25 a.m., and again he has to take a dose at 10 a.m. So how will we address that one? And second is we have renal friendly opioids. Similarly, in deranged LFT or bilirubin, high bilirubin rise, or in cirrhosis patients, if we have to give opioids, how will we manage that pain with opioids?
So for the first question, for end of dose pain also, you can actually use the, you can actually ask the patient to take 1 hour earlier also. Okay, that is not going to really make any difference to the dosing. All right, if the patient says that at 9 o'clock, I have this pain and my second dose comes at 9:30, you can actually ask the patient to take the medication at 9 a.m. itself. Okay, he doesn't have to wait for that particular time, and it is actually going to give him a coverage of pain that you can.
Ma'am, if he takes at 9 a.m., he can take the original timing 10 a.m.
Sir, I really can't hear you actually. Your
Ma'am,
voice is breaking.
Am I audible, ma'am?
Hello, Dr. Ravi.
Yes.
Is it possible for you to type out maybe?
Okay, ma'am, I will type it.
Hello?
Dr. Mani, you're muted.
Are there more questions? We can take 1 or 2 questions extra. So it's almost time. Okay. Dr. Ravi has written, if patient takes at 9 a.m., can he take at 10 a.m. again?
Yes, definitely. He can take at 10 a.m. because, if you have seen those slides, the effective analgesia starts only after 30 minutes. Okay, so we can actually repeat the SOS doses every 1 hour. So in CLD or cirrhosis or deranged bilirubin, how to manage pain with opioids in such patients? See, it again comes up to spacing, increase the spacing, all right, because opioids are going to accumulate in both, deranged liver function and deranged kidney functions, because they are metabolized through the liver and the kidneys, excreted by the kidneys. So in both these cases, you have to space the drug. Generally, morphine, the M6G metabolite of morphine, it will accumulate in both these conditions, both in cirrhosis and in deranged bilirubin and in deranged renal function. Okay, so space them. If you space out the time, then it is not going to harm. And if you see that even if you see the pain not being managed, then you can actually shift to fentanyl patches, because fentanyl is renal friendly as well as liver friendly. Does that answer your question, Dr. Ravi? Okay, so if patient pain relief stops 1 hour before every morphine dose, like 1 hour before 10 a.m. or 1 hour before 2 a.m. and so on, what should be done, as effect is short of 1 hour before every dose? So that means that the dosage of morphine that has been advised, this is for Dr. Rana, okay? The dose of morphine that has been advised is not adequate. Okay, you have to increase the dose. You have to take the total amount of morphine, that total amount of SOS doses, you have to add it to the already given dose, total dose that he has been taking, and then divide it into 6 different doses. That is going to actually take care of, because he experiences pain every 1 hour before the scheduled dose. That means that the oral morphine dose is not adequate.
Okay, ma'am, there's one more question. I think you can see it. Ma'am, could you please tell about the conversion of morphine to fentanyl patch, the dosage?
Yeah, I think I'm sorry, I missed out on that. See, when we convert from morphine to fentanyl patches, fentanyl is 100 times potent than morphine. Okay, if we take morphine as 1, then fentanyl is 100 times more potent than morphine. So 10 milligrams of morphine is actually can be converted to 25 micrograms of morphine. 10 milligrams of morphine every 6 hours. Sorry, every 4 hours, sorry. So cumulatively, it is 60 milligrams of morphine in 24 hours is equivalent to 25 micrograms of fentanyl every 72 hours. So there is a proper conversion ratio. I'll definitely share that particular slide also with Rajlakshmi, so that you get to know that.
Thank you, ma'am. Thank you, ma'am. Madam, do you have anything to add on naloxone as an antidote?
Sorry?
Do you have anything to add on naloxone, ma'am?
No, I don't think anything I need to add on that. Would you like to add, Dr. Manu?
No, ma'am. I was asking in case of morphine toxicity or overdose. Yeah, and for patients, yeah. How will you manage the naloxone?
Yeah, definitely. We manage opioid toxicities with naloxone and naltrexone only. But for cancer patients, I really have not come across any kind of morphine toxicity as of now, until and unless it is opioid poisoning.
Okay, ma'am. Thank you for the wonderful presentation and answers. We had a very good session. Since we are almost 8:30 now, we'll be having to limit the session. There are lots of questions. Thank you so much, ma'am, for the excellent presentation and for the participation from the candidates also. That is very good questions, very interactive session. Thank you, ma'am. Thank you so much for the discussion.
Thank you.